Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
We continue with This Medical Life now, and Travis, lupus, I know of it, but I don't know much about it. So I'm going to sit down at your feet and drink deeply from the cup of knowledge.
Look, it is this one's a hard disease to get your mind around. It's called Systemic Lupus Erythematosus, and look, it's a chronic relapsing inflammatory disorder, plus or minus fevers if you want to go down that line. But effectively, it's a disease of the immune system, which they say is loss of self-tolerance. So, and look, that's autoimmune disease in a sentence. So, look, I mean, just as a background, people have an autoimmune disease. You can get a variety of different manifestations. And look, we have a guest coming up, and I'm really wanting to question, because I've got lots of ideas about autoimmune disease, and this is such a diverse disease. 90% of people have joint involvement, 75% have blood involvement, either anemia or thrombocytopenia, or 75% have skin involvement, 60% nerve, 50% pleural effusions, 30% renal disease. Again, it's just such a conglomerate of different manifestations that it's really hard to get your mind around. How is someone getting kidney diseases? How is someone having Raynaud's phenomenon? And this is the same disease. So again, that's why we're here, because I'm trying to get clarification as to the disease, as to the testing. But if we look back, the word lupus is Latin for wolf. And if you read, the history of lupus, there's an association that, people thought it was named after, or wolf, because, people had their flesh devoured. It looked like their flesh had been devoured by a wolf. Now, there's no real evidence of that. And again, the name has changed, sort of, our evolution of the understanding for this disease has changed so much. It's hard to know whether that's real, but that's, what's said in the articles and historical accounts. So, you even go back to, Hippocrates, and he describes, ulcerative lesions, skin lesions. He calls it herpes asthenemos. Oh, for goodness sakes.
How many years have you been out of medical school? I think you can...
Oh, these words, these kill me. I don't use it. But this is what's called a gnawing dermatosis. And so the problem with that is, a few thousand years ago, anything that ulcerated, they could have put in this classification. And there's so many things that could have been, you can't really put an association with it in any certainty. But we do have the first time the lupus word was used in the 13th century, and this was Rogerus Fregati, and he used it to describe an erosive facial lesion. And then in the 16th century, we have Giovanni Mendati, and he used it in, for boils and ulcerations in the lower legs and extremities. But again, because this definition is so broad, they were just using it as a descriptive term, and as opposed to the diagnosis that we have today. So you just need to keep that in mind. But what do most people know about lupus today? Well, there's the classic butterfly facial rash. It's called a malar rash, where they get flushed cheeks and across the nose. And we even have evidence of some of this through history, where people have done paintings, because if there's a rash on your chest or on your legs, you can hide it, but a rash on the face is very hard to find. And there are some paintings and illustrations of people with this classic malar rash over their face. The interesting thing from a historical point of view is this was also associated with superstitions. And so, this severe inflammation and ulceration of the face conjured up fears. people have, thought they might have powers to transform, and, animals, the myth of werewolves and, very strange things. But in the 19th century, we have Rudolf Virchow, who reviewed all the medieval and Renaissance period literature and concluded that this lupus condition was ulceration and necrosis of the lower limbs, so a skin condition. And then we've got Robin Willan, who was a British dermatologist, who later went on to further classify this as a destructive lesion of the face and nose. And so we're starting to get the evolution of lupus starting to probably resemble something that we would recognize today. And it's interesting, there's an aside story from this, and it shows the complexity of the diagnosis they were dealing with. And so we got Niels Feinson, who was born in 1860. Now, I'm not sure if I'm saying this right. They say he's Faranisi Danish, of Icelandic descent. And he was described as an average student who worked hard to get his way into medicine. But the problem for Niels is he had a rare genetic condition called Niemann-Pick disease. This is a rare progressive disease where the body can't transport cholesterol and lipids into their cells. So you get this abnormal accumulation throughout the body. Now, he had an intense interest in light and the effects it had on animals and plants. And he believed light had a beneficial effect on himself and his condition.
Right.
And he ended up publishing an article in 1887 where he said light, and particularly UV, probably even had bactericidal properties. And he developed what we call the Feinson lamp. And this was a bright artificial lamp, and what it was to do was to treat people. And as happens in medicine and in history so often, which is just remarkable, the engineer who was working with him on this Feinson lamp, his name was Niels Morgensen, had a skin condition that was called lupus vulgaris. Now, he had tried heaps of different treatments, even surgery, and nothing had helped this skin condition that he's had. And yet he had, in developing this Feinson lamp, he must have been treated for it. And after 4 days, he had dramatic improvement of his skin. He became Feinson's first patient, and it was the beginning of phototherapy in dermatology. And so the interesting thing is lupus, as we know today, is photosensitive, so sun can actually exacerbate some of the symptoms. So he wasn't treating that lupus. What was he treating?
Yeah.
Well, it turns out he was treating cutaneous tuberculosis. So this patient had skin lesions of tuberculosis, and the Feinson lamp with UV was killing the bacteria and helping his skin heal. And so he ended up receiving the Nobel Prize in 1903. In 1904, unfortunately, because of his rare genetic disease, he died. But this shows the complexity. They called it lupus vulgaris. Well, it's not lupus, it was cutaneous TB. And so if you look at some of the other diagnoses, so they had lupus vorax. This was a descriptive term, but we do know it was possibly TB or syphilis or other infections that they called lupus. There was lupus pernio, which we now know as sarcoidosis. There was lupus miliaris disseminae facie, which resembles but is not granulomatous rosacea. So again, lupus back then wasn't lupus as now, so it's just important to keep that in mind.
A catch-all.
That's right. And so this term ended up coming out from the 19th century. It's called lupus erythematosus. Now, this is credited as Laurent Theodore Bier, and he initially called it erythema centrifugum, but his student published an article, his Pierre-Louis Elphi Cavenet, and there is a quote of the first description that they gave.
A rare condition which appears most frequently in young females who are otherwise healthy, attacking the face chiefly. Round red patches, slightly elevated, about the size of a shilling, gradually increase in size and sometimes spread over the greater part of the face. The edges of the patches are prominent, and the centre, which retains its natural colour, is depressed. There is heat and redness, but no pain or itching. It is essentially a chronic affection, though its appearance would indicate otherwise.
So this is a description of what we call discoid lupus now. So this is the most common form, cutaneous lupus. So in 1866, we have Ferdinand von Hebra. Now, he described what he called Seborrhea congestiva. Now, this is the butterfly malar rash, but it was also known as a sort of bat rash or a butterfly rash. Then in 1872, we have Moritz Kaposi from the Vienna School of Medicine, and he starts to piece together, this isn't just a skin condition. He starts to say there are systemic signs. There's things like fever, weight loss, lymphadenopathy, anemia, arthritis. Now, he then separates out the cutaneous form from the systemic form. And then we get Sir William Osler, who provides the name Systemic Lupus Erythematosus. Now, he studied between 1894 and 1903 about 29 patients. In this, he had a 15-year-old who had that malar rash, joint pain, and kidney disease. He had a 24-year-old, again, the malar rash, fevers and chills and pulmonary involvement. So we're getting bits and pieces all coming together. 1902, we know the photosensitivity is associated with the malar rash. And then we've got the acroasphyxia, which is the term we now call Raynaud phenomenon, where people get a really white area of the hand. It looks like it's sort of not got any blood flow, and it can be caused by a variety of conditions, but it's also associated in lupus. The interesting part with all of this is our major advance happened in 1948. This was Malcolm Hargraves, Robert Morton, and Helen Richmond at the Mayo Clinic, and they discovered what seems to be interchangeable as an LE cell or a TART cell, named after Mr. Tart, who was the first patient they found it in. And they found from his bone marrow that a cell had engulfed what looked like a nucleus of another cell. And again, if you can see a cell in your mind, you've got this big nucleus in it, and then just little blobs of nucleus pushed to the side. And honestly, it actually looks like a tart. Even that's why people think it's that, but it's not named after the pastry. And so what happens is it's a neutrophil or an eosinophil that looks like it's absorbed a lymphocyte.
You have put me off my morning tea now.
So this led them to the question in 1949, is this a cell problem or a plasma problem? And so what did they do? Well, they got the plasma from an SLE patient, and they used a bone marrow of non-SLE patients. And what did they find? Well, they found that they were able to induce these clumps of polymorphic cells around masses of nuclear material. They were able to induce these LE cells. And so the interesting part, the people who had discoid lupus, so the skin-only condition, did not get this reaction. So it wasn't in the plasma there for the people with discoid lupus. And the sickest patients, the patients who had the worst SLE symptoms, produced the most LE cells. So there was something in the serum that was causing this reaction. There was a signal. Now we now know that these are autoantibodies that are signaling for engulfment of these cells and what we say histones. So this is a structural protein of chromosomes. And so this was actually the diagnostic feature of SLE up into the 1990s, when antibodies took over as our testing. And so that's why when people are now doing antibodies, it's such a complex thing, because in the last 50 years, we've been discovering these antibodies that go along with this, but they're not exact, and there are sensitivities and specificities, and it is a really complex area. And that's why today we're going to bring along a guest to try and help us make sense, first of all, of the disease and the manifestations, but then also of the testing and what we can use in this area for them.
Do you ever hearken back to the ancient Egyptian times when the whole medical text was 108 pages?
I wish it sometimes it was.
mentioned a special guest will be joining us on this episode, and he's with us now. Our special guest is Dr Daman Langguth, Head of Immunology Department at Sullivan Nicolaides Pathology, or SNP, member of the Executive Advisory Committee and Chair of the Data Request Committee. Daman, welcome to This Medical Life.
Thanks very much, Steve and Travis.
Yes.
Looking forward to the discussion.
Oh, same here. Well, Travis has already warmed us up with the introduction, so let's get some context on this. How prevalent is systemic lupus erythematosus?
Well, it's a bit variable. So it does have a reasonable alteration in frequency of looking at racial or ethnic backgrounds. We don't have good data in Australia on our many and varied populace. We do think that the data we have suggests the disease is more frequent in those with Aboriginal or Torres Strait Island heritage. Overall, the rough estimate is a prevalence of about 1 in 2,000 people, and 9 to 1 of those would be women to men. In African Americans, the rate is as high as 1 in 700, and in Hispanic people from South America with Spanish heritage originally, they seem to have a rate of around 1 in 1,000. We think Asian people in general, so people from Southeast Asia, from Burma across to Japan, or at least not including Japan, have maybe a 1 in 1,000 chance, probably the same in Japan, but might be slightly lower frequency. So ethnic background or your genetic background is really important for this disease.
And if we build on that, then what are some of the risk factors that we need to be mindful of?
Bad luck is the risk factor for getting lupus. We have a lot of information about the immunologic changes, not the why. There are some very, very rare genetic causes of lupus in humans, but they are fantastically rare. Maybe there might be 100 people on Earth with those causes. Some animals get a lupus-like state naturally, not bred into them, but that doesn't seem to be frequent in humans. The disease, when we look at genetics, doesn't even look the same in some people. It can look quite different. So it's still a bit of an enigma of a disease. We have come a long way with some now very big research groups having over 2,000 to 3,000 patients in a database.
Yep.
Just not in Australia. We do have some excellent researchers, particularly at Monash in Melbourne, doing excellent work and participating in international studies in systemic lupus.
This is another one of those diseases where if you wanted to cut the medical fraternity some slack, it has to be in relation to lupus, with everything you've explained thus far. Perhaps, what are the main symptoms of SLE that we should be mindful of too?
Well, that's the difficult thing about lupus is diagnosis is not easy. Many people will have what we call an inflammatory arthritis, so morning stiffness, swelling of the small joints of the hands, myalgias, i.e. muscle aches. Often the arthritis really is arthralgias, so in other words, there's no synovial enhancement, it's actually just pain in the joints. And skin rashes, particularly photosensitive, but there are a whole host of other fairly kind of nebulous symptoms which mean that a lot of people could have lupus, but most won't. Things like fatigue, headaches. And some people present with them as the predominant feature, but most of the time people have a cluster of symptoms that, of course, when you're having them for, say, 6 weeks and you attend your GP, given that the frequency of lupus is 1 in 2,000 roughly in Australia, and the frequency of those symptoms from a myriad of other causes is much, much greater.
I was just looking at the classification of SLE. I see it goes into acute, subacute, and chronic. Is this useful at all? Is there any purpose for those, or is this arbitrary classification that doesn't really mean much?
So the classification criteria are exactly that. They classify lupus. So they're useful in doing studies. They're useful in you feeling better about yourself when you make the diagnosis as a doctor.
Yeah.
But they allow patients to be compared to others and then tracked over time. They're not diagnostic criteria because, as you can see, when you look at those traditional classification criteria, which have changed over the last little while, in fact, I would suggest if you went out there and took 10,000 people and used that classification criteria, you'd have a huge overdiagnosis.
So, given the wide spectrum of manifestations of presentations, looking at SLE, I'm trying to work out, is this one disease with many manifestations, or is this many diseases that we're putting under one banner, and it's almost arbitrary? This is like many diseases, we're putting them all together. Do you think there's we don't have
I think like lots of our diseases, if it walks like a duck, makes noises like a duck, it might not be a duck. And immunologically, it's clear that there are at least two large groups of people with the diagnosis of systemic lupus: those with interferon signature upregulated genes when we do genetic studies, and those without that. We have yet to actually delineate those all out and see if they are different manifestations. I think certainly lupus is not one disorder. There's no one gene that gives you it. There are multiple polymorphisms that influence it. And we know that genetic background makes an influence hugely, so that fibrotic disease, so scarring disease of various organs, may well be particularly correlated with genetic background, particularly in African Americans, and almost certainly in those of Aboriginal and Torres Strait Island heritage in Australia.
Damon, I'm almost scared to ask this question, but given what you've said so far, are there any predictors of whether or not someone's going to relapse or whether the disease is going to progress within a particular patient?
It really depends on what manifestations you get and have. Right. So we're not very good at telling people what might happen to them. We do use some blood tests to say, look, and you've got a greater risk of this than someone else. But it doesn't really help because it doesn't really change what you do. It's one of those things, how can you tell someone's severe? Well, when they come to you and they've already been severe. It's not useful for a patient. It's not really useful for doctors either. But yet, when you look at most autoimmune diseases, that's what is the greatest predictor. Having had severe disease ever is a predictor. We do know that renal lupus, so kidney involvement from systemic lupus, is something that we have to pay special attention to. And it's now accepted two parts of that illness. Not only is there's the grades of lupus nephritis, but there is the secondary fibrosis that occurs. And so if you have a fibrosing phenotype, you're more likely to fibrose than other people, then you do worse. So it becomes super imperative to control renal lupus. We're not that great at doing it. So lots of people who have traditional treatment, and that's traditional modern treatment, do not go into remission. Right. We have had a few drugs not available in Australia as yet, but have good outcomes. Lupus is a bit of a wasteland for pharmaceutical treatments in that more often than not, it's possibly the only autoimmune disease where I would say there's about a 50 to 70% chance the drug didn't work or didn't work as well as originally thought, compared to, say, rheumatoid arthritis, where we've now got a large array of medications that's quite suitable and control perhaps a significant majority of patients with rheumatoid compared to lupus.
I was just going to ask, since we've gotten on to complications, particularly glomerulonephritis, is there other complications that are be mindful to keep in mind for patients? If they're presenting or if they've got lupus, aside from kidney disease, which needs to be monitored, is there anything else, or is that the main one?
No, well, it's obviously the most feared one, but lupus can affect pretty much any part of your body except the liver, and lupus brain disease is something that is difficult. There are two parts to it. There's the high-level neurocognitive effects of the disease. So when patients with lupus, whether they're controlled or not, when they perform neuropsychiatric testing, they aren't quite as good as a cohort in their similar age and education, etc. And lupus brain fog that's often called. And patients' personalities often change. Their family members say they're slightly different. And that really is different to other autoimmune diseases. Then occasionally, usually in younger patients, patients get very, very, very severe disease and get a cerebropathy. So in other words, all of the little blood vessels in their brain become inflamed. That's obviously pretty obvious. You're sort of not very well in hospital, to say the least. Then there are the more concerning diseases that when we put people into remission now And remember, most of this is women, 8 to 9 to 1, diagnosed in their 20s. We know that the rate of cardiovascular disease is significantly increased. And I often tell lupus patients, lupus kind of makes you like a smoker. Very different mechanism of action, but the risk of heart attack and stroke are much higher in women. And usually it occurs when their lupus, after the lupus has been present for a long time. So we're talking maybe in the 50s. But still, having a heart attack or stroke when you've been very fit is somewhat of a challenge.
I'll say, are there any prognostic features that we can continue on to exploring right now?
None that are not just if you've developed damage. So in other words, if you have a destructive arthritis, which rarely occurs in lupus, if you've got that, you're more likely to get it going and need lots of joint replacements. The failure to respond to first-line treatment is usually a bad sign, but that's not telling you anything in advance kind of thing. We know that if you make double-stranded DNA antibodies at high titer, the majority of those people are more likely to have severe disease.
And just finally, before we're going to discuss more in depth about ANA, but is there any routine tests that are useful for doctors to have for their SLE patients to monitor for them going forward?
There are, but it very much depends on what set of tests the lupus patient has that are incorrect or showed signs of disease. So obviously, if you have a hemolytic anemia, you're going to monitor their blood count more often. If they have renal impairment, you're going to be checking urinary protein levels as well as cells in the urine and their renal function. And most lupus patients often end up with having blood tests each 3 months, some less so, some more so, depending on what their manifestations of lupus are. Often, because we're giving immunosuppressives, we need to monitor those drugs as well, so that some patients will even be on 2 or 3 immunosuppressives. And a lot of their blood testing may not be to monitor the lupus, but in fact, to monitor the patient so we'll make sure we're not doing them any harm.
As the layperson here, this is rather bleak, sadly. And I think, is that fair for a layperson?
No, look, it's probably not as bleak as I'm kind of sounding, because a lot of patients come under control.
Right.
It's just the difficult ones are very difficult. And I don't mean that the patient's difficult, their set of diseases is difficult and can be very challenging. And once we get past first-line treatment, or perhaps once we get to second-line treatment, really our treatment options drop off, and we have to use medications which either failed in a study but failed for reasons that we think was study-related, or go cap in hand to high-cost drug committees or pharmaceutical companies to ask for access to a drug that isn't readily available in Australia.
All right. Thank you. On that note, let's pause for a moment and come back and look at more of the detailed investigation of testing. Welcome back. If you've just joined us or you've jumped to this part of the podcast, Dr. Daman Langguth is with us as we're working through lupus and all the things related to lupus. There you go. The layperson's done his bit. Dr. Travis Brown, let's take us into the final part of this episode.
So now this is probably one of the most challenging areas of pathology. The ANA test, anti-nuclear antibody testing. It's a widespread test. It's ordered a lot, but I'm trying to get clarification today as to, when do we order it? What is the interpretation? Because I often get this question a lot of the times during the week, and sometimes I have an answer and sometimes I need to refer to someone like Daman, just because it's such a challenging area. So just looking at it, the ANA test has 2 parts to it. We've got a quantitation telling us the intensity of it. We also have the staining of it, so it's homogeneous speckled. Breaking it down probably into 2, Daman, can you tell us about the significance of quantitation of ANA?
So ANAs have been around since the 60s, invented by Dr. Eng Tan, or discovered, as you were. And we originally used to look at rat livers. And then cells were made, which are immortal, which have a much bigger nucleus, which enables us to look at them a great deal better. the chance that you have lupus increases as the concentration or titer of the antibody goes up. So we often, and different labs report them differently. They're not necessarily wrong or right. So the titer or level of the ANA varies. And generally, the higher the titer, the greater the chance that you have lupus. However, ANAs are very common in the general population and being more frequent in women than men. So even in the 20s, the chance that you're ANA positive is at least 5% if you're a female. So in other words, 1 in 20. But as I mentioned earlier, 1 in 2,000 people have lupus. So you can see the number of people who have a positive ANA test dwarfs the real population. So in the general practice setting, where even if they fulfill lots of symptoms, your chances are still going to be greater that you won't have lupus. The test really acts as a negative indicator. So in other words, in the setting where a patient has lots of symptoms, which could be due to lupus, a negative ANA says, you're right, they don't have lupus. Mm. So if you look at people in their women in their 60s and 70s, you're getting up to sort of 30% positive rate. Now, of ANAs, most of them, of course, will be 1 in 80 or 1 in 160, but still, it's not a great diagnostic test for including something. It is a great diagnostic test for excluding things.
Right. So when a patient, now I get a lot of queries about the patient has a positive result of ANA, which is 1 in 80. And it's the significance of it, as you said, is probably almost nothing. And it's hard to say, is there a level at which you would say, well, this is quite significant, we need to investigate further?
I would say that's where you look at your, albeit classification criteria, mm-hmm. and you try and say, what is the chance this person has lupus without using the test? So unfortunately, we have these things, classification criteria, which then, of course, become a circle argument. If you exclude an ANA, how do you make that diagnosis? But in your brain, you can do that. You can say, okay, what other features do they have here? And if one of them is fatigue, well, that's pointless, because fatigue it could be any disease on earth, including, as far as we can tell, just fatigue. I think you've got to say, well, look, what's the chance here? Because occasionally you can see people with just predominantly skin lupus who'll have an ANA of 80, but I certainly wouldn't want to be promoting that that's a common thing and that those people all need to be investigated. Once you're ANA positive, you're probably going to be positive forever.
Right.
So even if the titers probably don't change very much. We don't use change in titer to monitor. People get worried, my ANA titer's gone up 3 times. It doesn't matter. It's got nothing to do with anything. And some of this is because our testing has got so good. Modern microscopes and staining techniques mean that we can actually see things we couldn't see before. Mm. So the apparent increase in frequency of ANAs is somewhat of a lab phenomena, but I think just the fact that we have a lot of other diseases which can be associated with ANAs. Also, aging appears to be associated with it. Being female is associated with it. So at any age, women have 10 to 20% greater chance of being ANA positive. Mm. But that doesn't mean anything for them. It doesn't have any reflection on how they've lived or risk factors.
Mm. So then moving on to the staining, the staining result that we give. So let me just give the list that we give. We give a homogeneous, speckled, nucleolar, centromere, nuclear membrane, cytoplasmic, and atypical speckled. Now, this is a result that's the options that come through as to what type of staining it comes through. Is there any more significant than others when we give that result in that report?
We know that if you look at an unselected population, nucleolar ANAs don't actually have any correlation with autoimmune disease. So in other words, they don't pick people out as being prone to any given autoimmune disease more than a negative ANA. But in patients who have a diagnosis of a different autoimmune disease, scleroderma, when they are ANA positive, probably about 60 to 70% are positive, they're nearly all nucleolar or that centromere. The patterns, in fact, you mentioned are a bit more complicated because there are about 28 patterns, and I played a little part in setting up the international consensus on that, but really it's for immunology nerds to some degree. The pattern is a little bit, it's not associated with the chance you develop disease, but it is associated with some, with the secondary testing, so that your pattern of ANA, if it's homogeneous, you're more likely to make double-stranded DNA antibodies, and we can detect those. If you're speckled, you're more likely to have an antibody, say, against Rho or La or SM or RNP. So there are some kind of extra things, but they don't tell you the risk of someone developing lupus.
Right. So then you've mentioned that probably doing follow-up with regards to ANAs is not useful because it most likely doesn't change. So is there any role in repeating an ANA or even monitoring ANAs?
No, certainly not. I always tell people we monitor patients, not their blood tests, unless they're part of the disease, of course. If you've got a known diagnosis of lupus, there is no real need to repeat their ANA ever. There is no real need to repeat their ENA ever as well, unless they had a new manifestation. But it is very, very rare for a patient with a known diagnosis of lupus to change their so-called ENA pattern. So that's a subgroup of secondary antibodies. Most people, by the time you develop clinical lupus, you've got all of the manifestations in your blood that you're going to. We actually know from a very good study done in the US where they looked at veterans. Now, in America, everyone who's a soldier donates blood each year. I'm not sure they still do, but it wasn't really a donation for them. They give the blood, and it was for them veterans to be able to monitor diseases, which may not, of course, exist at the time or not be known about. And so they looked at all the people who had been given the diagnosis of SLE in the American military, and they looked back, and you could see that they first had positive tests about 7 years prior to the diagnosis.
Oh.
And there's a fairly reliable progression of positivity of tests over time, so that it really showed that, you know, if you had an ANA, and let's say you went and saw a different GP and you'd forgotten you had the test before, they then look up on a system and see, oh, look, 10 years ago you're ANA positive. We know that those people aren't going to get lupus.
Right, okay.
So that's quite useful to know. And it was only that study that really showed, and what we've always thought is that autoantibodies don't just arise. They take a fair while. And lupus is an exceedingly complex disease that, as we mentioned before, is not one disease, maybe two or three or perhaps even more, and greatly mitigated or deteriorated by your ethnic background and the genes that you have. So that's why we don't monitor. You know, we know that the ANA will have been positive for ages. Right. And doing it again doesn't help you.
Mm-hmm. Now, I'll just touch on it. We won't go into it into depth, but the ENA that you mentioned, does that come under the same rules as ANA? Effectively, once it's positive, because often these are ordered together, pretty much ANA/ENA, yes. And it goes into this realm. Is that also a realm that once it's positive, don't repeat it again?
Exactly. The reason to repeat it was you didn't believe the first time.
Right.
And that's actually okay, because the testing for extractable nuclear antigens, or ENA, has become more sensitive but probably less specific over time due to the tests available. So there are good and bad things. And that if you didn't believe it or you thought it was wrong, the other reason is that if you are ENA negative and a woman and planning pregnancy, we always check the ENA again prior to pregnancy, because there are two antibodies, Rho-La or SSA-SSB, which can lead to significant complications in the pregnancy, i.e. complete heart block of the fetus, and we monitor that. So there are some specific indications there, but in, let's say, a 30-year-old man with lupus, they're not very common, then if you're ENA positive and you have one positive, there's no real reason to ever check it again. It'll always be there.
Damon, just something you said at the beginning of that was ENA, if you do repeat it, often it's you didn't quite believe the first time round. The thing that made my mind move on to next is, as a GP, when do you make the decision to refer to a specialist?
I think where you've got a clinical syndrome, which could be lupus, and supportive tests. You may well even have had a skin biopsy And if that shows lupus, well, you've got lupus. In fact, it's not quite as easy as that, because there are some conditions that look like lupus in the skin, but you don't have lupus. But these are why immunologists and rheumatologists exist. So I think, having some supportive tests, but knowing that they have to be interpreted in the light of the clinical background.
And just finally, is there any tips and tricks you have for GPs that might not be in the textbook, or just really useful pieces of advice for them with SLE patients that you might have had?
So we like to, obviously, the specialist role is the specialist disease, but then now I think in all specialties that deal with chronic disease, we want to keep an eye on other things. So the fact that we still use corticosteroids, we need to think about bone health. I mentioned before, we're worried about long-term cardiovascular disease, so we're looking at weight management, exercise, but at the same time in lupus, trying to avoid the sun, because maybe 30 to 40% of patients have what we call photosensitivity. So their rash has been made worse, but occasionally their actually underlying systemic disease can be made worse by the sun. And then, of course, we put our patients at risk of vitamin D deficiency because some patients are very good at doing what their doctor said. As we know, some aren't, but some people, might really suppress their vitamin D. And of course, if you are a dark skin, anything not pasty like me, that means that you are less likely to absorb vitamin D, because that, after all, is the point of melanin in the skin, to prevent cancer, and it makes it harder to absorb more vitamin D. So if you are of dark skin and we tell you not to go in the sun, even though it's Australia, some people are really good at that, and you might actually introduce osteoporosis into those people. So there's a lot of wellness kind of concepts that come along, because plenty of patients with lupus will be in complete control. They will not have active disease. So we really got to think, how can we keep this person alive as long as possible? Because we know that lupus probably takes maybe 10 years off your life on average, and not just because of the disease itself.
Well, on that note, Dr. Daman Langguth, thank you again for joining us on this podcast and sharing your wisdom with GPs and all our listeners.
Thank you very much.
And thank you, Dr. Travis Brown. Of course, it's been a pleasure. Another journey you've taken me on.
Thank you.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a PathNotes Proprietary Limited production.
Life is uncertain. It's okay to feel stressed, anxious, worried, or frustrated. It's normal. With CalHope's free and secure mental health resources, it's easy to get the help you and your loved ones need when you need it the most. Call our warm line at 833-317-4673 or live chat at calhope.org today.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.